Thank you, Indu, and it's a real pleasure to be here at a meeting on PAH, an area that we really need to, as pulmonologists, improve. And that's the title of my talk, which I have to thank Madhukar for agreeing to assign to me, because it's something I really feel is a deficiency in pulmonology practice, not just in Mumbai city, but across the country. Can I have the first slide in? And this pulmonary artery often tends to get neglected, and the whole system, the pulmonary vascular system between the lungs and the heart, is a situation where no one really takes responsibility. As we often say, someone has to take accountability for the pulmonary vascular system, and the pulmonologist will say, oh, this is probably more cardiology, and the cardiologist doesn't have the interest that they have on the left heart hemodynamics as much on the right hand. But interest is increasing, and as one person put it up on a slide once at ERS about 15 years ago, he said, these are the drugs that we have for pulmonary hypertension, idiopathic pulmonary hypertension. The slide was blank, and this was about 15 to 16 years ago, if I'm not mistaken. And then in a few years, you had a slide full of PDE5 inhibitors, endothelin 2. Okay, a little quiet there at the... Little, right? There's a lot of noise coming from that side. So they had PDE5 inhibitors, you had endothelin receptor antagonist, prostacyclin inhibitors. Literally, within a few years, you had 3 groups of drugs. So that really changed things. The slide is not changing with this. Okay, that's great. Thanks. So there is a lack of good training in pulmonary vascular medicine. And when you do chest medicine, I think one of our big issues is there is no training in general medicine. So I think a lot of chest physicians, including me, have a problem when it comes to general medicine training, and we learn along the way. So we get our general medicine training, we learn with colleagues who are good in general medicine. So that is a mild deficiency, and within the specialty itself, pulmonary vascular medicine is not focused as much as it should be. The other thing is that I often see in practice is dual pulmonary hypertension therapies are prescribed just based on an echo PAH, and I can understand there's pressure from pharmaceutical companies on physicians, pulmonologists, cardiologists, but just because you see an estimated pulmonary artery pressure elevated, you don't get onto a PAH-specific therapy, and this is a common error. There's also, I wouldn't blame pulmonologists alone, there's also a significant lack of interest among cardiologists to talk to pulmonologists in detail on pulmonary vascular hemodynamics, and that's another area. And you have average echocardiography, and echocardiography, okay, our ICU intensivists I can still understand. We want to know if the IVC is full, you want to know the left ventricular ejection fraction, but when it comes to specifics on an echo, you need a good echo. Just like we pulmonologists say there's a huge difference between a spirometry test and a good spirometry test, the same applies to echocardiography. It's operator dependent. And there's also poor availability and the cost of inhaled prostacyclins, which is a problem for pulmonologists who need this group of drugs to treat group 3 PH. And lack of right heart cath, which we're going to hear about hopefully during the day. So I'll just focus on 3 things in my talk: what's new in PH, the right heart echo, and the emphasis on why the right heart cath is important, and a few new trials that have come up. And for those of you, we are going to have a case-based approach, which is really exciting if you ask me. It's a new way to conduct a CME, and I have to compliment Indu and Madhukar for designing a program that is based on cases because it allows more interaction. And I know we know the ERS ESC guidelines, but for those of you who are not aware, this is very important. The classification changed, the mean pulmonary artery pressure cutoffs, the wedge pressure, as you can see here, and the PVR. And so you know when the PVR is normal, this is less likely to be pre-capillary pulmonary hypertension or a problem in the pulmonary artery. The PVR in pre-capillary, post-capillary pulmonary hypertension is usually less than 2 Wood units. The wedge pressure is high, as you all know. We don't often talk about this, right, to our cardiologists because we don't have too many right heart caths to look at. And then you have severe and chronic lung disease where the PVR is more than 5. And these are patients which really need a lot of our attention and along with the cardiologists. So I, as a pulmonologist, can tell you about group 3 because that's what we treat the most and that's what we see the most. But we also need to be aware of what's available for group 1, which trials in group 3 are slowly increasing. And I'll give you a case scenario at the end because I thought I don't want to be missing out on cases because Sujit has kept so many cases for today. I said I will also put up a case which is so relevant in this space. Increased oxygen need, reducing exercise capacity, increased risk of adverse events. As Sandhya was telling me, look at the DLCO, the KCO, those are down. That will pick up an early sign and a worse prognosis. And group 3 includes obstructive, restrictive, and a mixed approach. It includes also obesity, hypoventilation syndromes, high altitude. Some people are living at high altitudes. Many people today in the world live at high altitudes, and their risk of developing pulmonary hypertension is higher, and that's usually group 3. And of course, developmental lung disorders, which are rarer in our practice. In this group 3, most of them have no pH on the echo, a very mild to moderate pH. It's a ventilatory exercise limitation. Remember, it's all about ventilation in the lung. So that's non-severe, which is about 20%. So 20% is mild to moderate, which you'll see on the echo. There is no need to treat that pH most of the time. In fact, never. And Tala is here, a cardiologist with interest in pulmonary vascular medicine, and his input during the day will be very useful, I think, in telling us that this pH should be back to your pulmonologist, treat the lung. But there's about 5 to 10% of those patients we see with chronic lung disease who have a pH where it's a circulatory exercise limitation. And those are the patients that we really need to treat the pulmonary vascular system. We'll hear more about that. And why should we worry about group 3 pH? Because it is the worst prognosis pH. Among all the pHs, it has the worst prognosis. So when you have a patient with bad pulmonary hypertension, we pulmonologists, physicians or cardiologists see a patient with chronic lung disease doing badly, group 3 does the worst among all the groups of pH. And within that group, I have to say, within that group, interstitial lung fibrosis is even worse. The area I'm interested in has even a bigger problem, and that's probably why the interest in pulmonary hypertension is so much among patients, among specialists in ILD. The evaluation, why do you do this evaluation? You want to exclude left heart disease, CTEPH, IPAP, and we'll hear more about this. Why would you ask for the right heart cath? Also, oxygen requirements, the disease trajectory, DLCO, blood gases are so important here. There's mixed venous saturation, which we'll hear about, I'm sure, during the day. Pro-BNPs, CTs, VQ scans, cardiac MRI. So these are all areas that some of which we are not very familiar with on a regular basis. And of course, the need for the right heart cath. And if you see those ERS, ECS, this is a beautiful slide which obviously you can't memorize, but you must know about on what all to look at in an echo or what all to ask your echocardiographer. And as I said, we were in the nascent stage when Indu was working with us in understanding what the things you need in an echo, which we don't often ask for, and tells you a lot about what all you need to see. And if I had to boil it down to a few things, the estimated right ventricular systolic pressure based on the TR jet velocity, increased RV size, area of more than 18 square centimeters, increased RA area, increased RV size, that was RA area, septal flattening as the RA dilates, and a reduced tricuspid annular excursion. And of course, the IVC. The IVC is dilated and not collapsing. That itself tells you your RA pressure is over 10 in my estimate. So these are such important things on an echo. Now I'm seeing an increasing number of echo reports that report this, which is a really good sign. So we are getting that information more and more on good echocardiography. There's also a DOE gap scoring system now, which includes the 6-minute walk desaturation and whether the patient needs oxygen on ambulation. Excuse me. So this changes prognosis. So ambulatory hypoxemia, how many of us actually prescribe oxygen on ambulation? We know that these patients, if they use it on ambulation, will do better. So it's important to include it in the prognostic classification. And even in ILD patients, the moment they have significant ambulatory hypoxemia, we are already starting that conversation on transplant and that it's a possibility, especially if they're younger patients. RHC, I know very little about how to do a right heart cath, but I do know the normal values, and I think it's always important to know. It's like when you do a lung pathology, you should see normal lung histology first. So normal right heart cath values are important, and I think we should know those. So this is just to put out the normal values. When you see abnormal values today, you don't want to miss it during the cases. And any PVR below 2 is usually post-capillary, LV. Left ventricular failure, you do a cath, PVR will be less than 2. PVR more than 2, left ventricular failure, there may be a pre-capillary component. And why do we do right heart cath? Well, there are at least 3 good reasons, if you ask me. One of them is the third one, unmasking left heart disease. And you want to know, is there diastolic dysfunction, high LVEDP there? Pre-transplant evaluation mandatory, clinical trials and registries, and of course vasodilator use on a compassionate basis. It's good to have a right heart cath data before you start it if you want to start PAH. So I think there are a lot of indication, and it helps us understand, and maybe in the future echo will get even better and better and we'll need less and less, but at this point of time I do think we need to do it more often. When do you not suspect group 3 PH in the right heart cath? If your PVR is more than 5 or 6, this is unlikely group 3 PH. At least in a COPD patient, this is a separate problem. Mean pulmonary artery pressure over 35, there's something you're missing. Mild airflow obstruction in COPD, severe PH, think of group 1 PH associated with it, CTEPH, pulmonary veno-occlusive disease. ILD, PH is far out of proportion to the fibrosis. Again, think there's something else going on here. This is PH with an ILD overlap. There's something, you need to focus on the vascular pathology more or as much as the fibrotic pathology. And we have seen patients treated as ILD for years with steroids, and the actual problem, and not improving, the actual problem is actually the pulmonary hypertension. So in an ILD patient, always look at that echocardiography carefully and think about, especially when you see high pressures, low threshold to get a right heart cath done. And why is it important? Because of these reasons. These drugs don't work. Okay, in COPD, none of them work. Sildenafil, maybe, it's not recommended, maybe in a few patients where it's disproportionate. In ILD, however, the interest has increased because of treprostinil and systemic prostacyclins. There's basically some expert panels that have suggested that you could consider it, but they're harmful. So please understand, endothelin receptor antagonists and PDE5 inhibitors can actually harm the patients based on trials. So the key thumb rule is severe PH with ILD, think of ILD and PH, and severe PH and COPD, suspect a misclassification. You've probably got it wrong. It's either group 1 or CTEPH. Finally, a few thoughts on treatment before we end. Remember, survival is worse in group 3, and in group 3, survival is worse in IPF and interstitial lung disease. So ILDs do worse in the group 3 itself. Oxygen therapy we know helps, but the evidence is largely in COPD. but symptoms are improved in ILD. So just because there's no evidence, it doesn't mean we don't give oxygen to our ILD patients. It improves breathlessness, improves exercise tolerance, and nocturnal hypoxemia and high altitude travel, they will need oxygen. So Schiller is hopefully launching a machine for high altitude PO2 testing, and we'll have that machine in India hopefully soon. We've been asking them about that because many people are going to high altitude and want to know if they're fit to travel to those altitudes. I'll give you one case example here. This gentleman was 66 when I saw him, IPF, slowly progressive edema, and PAS, pulmonary artery systolic pressure, 60, right heart cath. These were the measurements, sildenafil 20 milligrams 3 times a day. And another gentleman, and this patient actually got better with it. So the pH was separate. And this was a 77-year-old male with radiation fibrosis after CA lung and developed pulmonary hypertension, as you can see, a right heart cath done. Echo pulmonary artery pressure 60, and you would have thought radiation fibrosis secondary to the disease. We initially gave him sildenafil 20 milligrams 3 times a day because that's all. We were only thinking of sildenafil that time in July 21 to October 22. In October 21, we switched to tadalafil because it was easier to give. And then he imported iloprost. And from 21 to 22, he started taking iloprost. I mean, this is not a story we often see because we don't use these drugs very often. 10 to 20 micrograms a day, to take it 6 to 8 times a day. Fairly wealthy patient, so he could import the drug. He's on tadalafil 40 milligrams. Then we switched him from September 22 to November 24 from inhaled iloprost to inhaled treprostinil, which he also imported from the US. 48 mics 4 times a day, gradually increased the dose of treprostin because he didn't want to take it 8 times a day, the inhaler. He said, I'd rather take an inhaler 3-4 times a day. He expired in November 24, but just see his 6-minute walk distance. 82 meters in June 21. And then as we gave him low-dose sildenafil, his 6-minute walk improved. And then you can see the iloprost, how it improved further and how it got even better with the treprostinil. You know, so he was as good with iloprost as with treprostinil. So inhaled prostacyclins work. And he got another 2 years of decent quality of life, and he died at about 81. In November 22. What I'm trying to say is don't miss this out. You know, I'm not saying everyone is as wealthy to afford to import these drugs, but when they are available in India, or when someone asks you, it should not be that you don't know that there's a drug that can improve quality of life and longevity. This drug really changed things in PH. Unfortunately, we don't easily have it accessible. Key parameters that make patients improve are a low DLCO, a baseline PVR more than 4. This patient had a baseline PVR more than 5. And as you increase the dose, you're going to get higher and better effort tolerance and better results. You can see the forest plot there. So the higher, as you push up the dose, you get it. And the side effects are almost negligible. And there's so many trials in PH, and I just want to tell you 2 negative trials. So do not use ambrisentan in group 3 PH. There's a risk of disease progression and hospitalization in this study. And the riociguat, the Steve Nathan's trial, showed that riociguat can worsen PH in patients with group 3 PS with ILD. So we need to know what not to use as well. The STEP IPF was an equivocal study, and so we still try sildenafil sometimes. We've got to be careful. We don't really know. The subgroup analysis showed some benefit in 6-minute walk distance. Then we have this new drug, sotatercept, and I'll probably have to defer to people like Thala to tell us more about this drug. We don't know if it works in group 3, but there is some evidence that it could. It's approved currently for group 1 PH. 45 or 60, that's the dose. I would believe that it could work for group 3 PH like the inhaled prostacyclins, but I really do not know. But it's a new drug, and a lot of the cardiologists I've met are excited about it. So we need to hear more about this drug during this meeting. And finally, palliative and supportive care. I can't tell you, rehab is important, transplant evaluation is important. I don't want to go into those details. We can discuss that as the day goes on. But we need to understand that palliative and supportive care is very important in today's day and age. And I think we need to move away from a mindset which is how many patients do I see every day, how much do I earn, and how many. The best pulmonologist or the best cardiologist is not the person who has the maximum number of patients admitted under them. And I think we all know that. But that's what hospital administrations sometimes want of us, because as you know, in India, a lot of hospitals are now taken over by private equity, and there are pros and cons of it, and I'm sure a hospital has to be profitable to sustain itself, and young pulmonologists are employed on better salaries, but there's also a downside to it in that too many things are happening on the patient which is not necessarily in their best interest. And Charles Goodhart's law exists on this, and Charles Goodhart said when a measure becomes a target, it ceases to be a good measure. And I always reflect on this, so if you can't have targets in medicine. Healthcare is not measured by targets. However, you have to measure something, right? And the guru of management said, if you can't measure it, you can't change it, and you can't do. So you need to measure certain things. And sometimes I feel we should do studies on how many patients leave our clinics actually satisfied with the consults, how many patients leave hospitals satisfied. I see a lot of patients grumbling. It's not just about high bills, but the time they got to spend with the consultant while they were in the hospital. And if you see fewer patients well, I think it makes a much better difference than seeing too many patients not so well. And so that's something one should focus on. And so to conclude and to set off today's meeting, PAH should be identified in chronic lung disease. Echo and right heart cath are critical in getting our act better. And we need to use this and interpret it well and learn from cardiologists who are immersed in this space. Treatment options are limited, but they remain an exciting area of research, and we're getting newer and newer drugs. And so even if we use the PDE5 inhibitors, where in group 3, we need to use them cautiously. In group 1, the options are unbelievable today. I mean, we have hardly sent a patient with group 1 PH for transplant now. They are largely being managed with medication. So we're going to hear a lot about group 1 as well. But never forget palliative and supportive care. Thank you very much. Thank you.